This is Dr. Sakhnini speaking, welcoming you to this case of ganglion cyst that involves the DRUJ and pushing away the ECU. This is the axial MRI showing the ganglion cyst in the DRUJ area, pushing away the ECU from its shallow groove. For comparison, we have intact ECU sitting in its groove for comparison. Now, in this case, this patient had pain on the dorsal-ulnar part of the wrist, and as such, we opted for a surgical intervention. This is a surgical approach, a lazy S that is mounted on the fifth compartment, the EDM, dorsal-ulnar approach. We start by skin incision, followed by homeostasis with the help of a bipolar and gentle dissection to take away the sensory radial branches of the SRN and the dorsal ulnar branch of the ulnar nerve away from our surgical field. And as we dive in deeply, we will encounter the fifth compartment. We will be opening it and taking away the EDM radially and excising the ganglion. So as we have seen in the MRI, there is a ganglion cyst that is under the fifth compartment, pushing away the ECU, causing some symptoms of pain with instability with this young patient. This is a unique case, as we are going to stabilize the ECU from a dorsum approach on the radial side of the ECU. Now we have exposed the EDM from its compartment, opening the extensor retinaculum proximally and distally, and we will take it away with the help of a retractor. So this is the EDM. You can see even the muscle fibers that are distal in this case. Now we want to open the extensor retinaculum that we will use and utilize later in the stabilization process of the ECU. And once we open the retinaculum, we fall on the ganglion cyst that is now come into view on the dorsum of the ulnar head and neck. At this stage, we will excise it from the bone and try to take it away as one unit. Now, as the ganglion involves the dorsal radio-ulnar ligament, some of the fibers will be excised in order to prevent the ganglion from coming back. Part of the attachment of the ligament to the ulnar head will be damaged, and as such it is necessary to reinsert it back. We will use a knotless anchor to reattach it back to the ulnar head. So we take out the residual ganglion from the ulnar head. Now we can see the dorsal radio-ulnar ligament and the cartilage of the head of the ulna and the ulnar styloid. So the next step would be reattaching this ligament back to the ulnar neck in order to stabilize the ulna, and for that we will need a fiber wire that we will put it in the ligament, whip stitch it. We will have a double threads in order to use a knotless anchor for this mission. So this is the first one, the dorsal ligament, part of the TFCC complex, and we'll be putting another one. So this is the first one, and now we are putting the second fiber wire suture. We have 4 strands Now we do drilling the neck of the ulna. This is a Conmed knotless anchor. Now we will put all of the strands inside the anchor, and then we will reattach it to the neck of the ulna and screw it inside. This will reconstitute the dorsal radio-ulnar ligament. We can see it's very stable. We will use these strands also to restabilize the ECU. This is another 4 strands of a Conmed through shot, and with the help of these 2 rows and 8 strands, we now will stabilize the ECU subsheath and retinaculum together and take them dorsally and restabilize the ECU. We will start working on the proximal part. As we can see, every strand goes inside the subsheath and then the extensor retinaculum. So the retinaculum will be used and utilized to give the stability of the ECU using these sutures and 2 anchors. Now we could also put a groove or deepen the groove for the ECU, but I think this is redundant, and the way we used here is using the soft tissue with the help of the anchors as stabilizers. We know that the ganglion was a part of the instability of the ECU, so when we took it out, now we think that's enough to use 2 anchors to stabilize the ECU and the whole length of the ECU. Now we go distally and stabilize the distal part of the ECU subsheath back to the bone, and we can see here that the holes in the ulna are dorsal and they are under the EDM, so we took it much radial and dorsal, and this will give us the stability that we need. I think we believe that this would be enough to help the patient symptoms. Now we will suture these strands, and one by one, starting distally, going back proximally. As we can see here, these fiber wires have metal inside, and they are strong, and they will help stabilize the ECU. So to summarize up, this is a young patient who had a ganglion cyst under the EDM, pushing away the ECU, involving the DRUJ, causing the patient symptoms of pain and weakness, and snapping of the ECU out of its place. We excise the ganglion, we reattach the dorsal radio-ulnar ligament back to the ulna, and then we stabilize the ECU with a double row anchors utilizing the subsheath and the extensor retinaculum. We irrigate the wound, checking the range of motion, and then we will close the distal part of the extensor retinaculum. The proximal part has already been used to stabilize the ECU, so the next step would be closing the subcutis with the help of 4 vicryl suture, followed by closing the skin with a rapid vicryl 4 sutures that dissolves in a few weeks. The patient had a good outcome following the surgery. He needed an occupational therapy to work on the flexion extension and supination, but he got back a good grip and a symmetrical range of motion, prosupination and flexion extension. I hope that you enjoyed this video and could utilize part of its elements in your practice. I will just show the clinical outcome, showing the range of motion of this patient. This is the flexion, extension, supination, which is not bad at all, and pronation. Thank you.